Hello, my name is Ben, and I'm going to be presenting today's live webinar coming from King's College London. So I am a resuscitation officer, which is a bit of a bizarre job. Essentially, I'm responsible for clinical audit. I teach a lot of life support, so basic life support, CPR, resuscitation, and I have clinical commitments, which means I'm part of the cardiac arrest team, one of the team leaders, and yeah, that's my day-to-day job. Before that, I was, an intensive care nurse by background, so looking after people in multi-organ failure, some of our most unwell patients. And that was at Guy's at St Thomas's, which is where I worked after I trained. I studied, so when I was at King's, I graduated King's in 2014, and I studied Bachelor of Science with honours, adult nursing. And went on to work at Guy's at St Thomas's in a number of jobs. So I worked on the Lane Fox unit first, which is kind of respiratory high dependency weaning for people who have become dependent on mechanical ventilation, and also supporting people who are dependent on mechanical ventilation, kind of tracheostomies. I then worked in the cardiothoracic intensive care, which was very fast paced, and then moved into general intensive care, so ECMO and multi-organ failure. So today's topic, 5 top tips for difficult conversations, is a key part of my job, really. Difficult conversations, we're never really taught how to navigate them, and we're never really taught how to, or what to do and what to try and avoid. I think I learned pretty much through experience, and you kind of, you pick up on points from other clinicians, and you see things in practice that you kind of take snippets from, things that you think you could do well in the future. And with every element of practice as well, we always see things that you think, next time I'd like to try and avoid that, or perhaps there's another way that it could be done. Why do I think it's really important? I think this idea is really important, that a normal day for us, a Thursday afternoon for us, for me, in my job, might be the worst day of somebody else's life. And I think especially at times where we're dealing with death, or we're talking about real life-changing circumstances, not only for our patients, but for the relatives, for the families of our patients, we get a chance as nurses and midwives to decide how those memories are created. So the words that you use, the language that you use, and the facial expressions that you make can determine how people's memories are of really, really key milestones in their lives and the lives of their family. For the audience, there'll be a recorded version of this webinar, which will be available a little bit later. And for people who have just joined, welcome. So I'm going to kick off. I think you can ask questions as we go along. I'll try and answer things as we're going along, or I'll just keep things to the end. So I think there is an option to submit questions. And I'll, my contact details and email addresses and things I'll leave afterwards. So there's always an option to chat later. So moving on to top 5 tips for difficult conversations. Number 1, plan the conversation. I think this is really, really critical. So for me, I tend to split it into 2 kind of categories. So the first part about conversation planning happens before you've even spoken to the family, before you've even gone into the room. First of all, I like to find out who I'm going to be having the conversation with. Is it a doctor? Is it another nurse? Who are they? What's their background? And how have they met the family? In what context have they met the family? What's their role? What's really, really key is a collaborative approach. So it might be the bedside nurse looking after the patient. It might be some specialists. It might even be people who you might not think of at first, perhaps faith leaders. I've had difficult conversations with families in the past where their religion is really important to them. And I've often found in clinical practice that involving faith leaders, involving people who have an insider insight into their religion can be really valuable. And I think families really, really appreciate that. What I think next is important is to establish roles in the conversation. So it's about planning the conversation. What message do you want to get across? How are we going to have the conversation? And at what point do we need to change topics, move on, evaluate what it is that we're saying? My next thing about planning the conversation, so still staying in tip 1, would be to think about the room and think about the space. So the layout of the chairs, are there enough chairs? Can we guarantee the room is quiet, so away from the hustle and bustle of the intensive care unit or the emergency department? Can the room be locked? And this is really, really important. Are you likely to be interrupted during these important family conversations? It interrupts the flow, it interrupts the privacy, and most importantly, the dignity of the family and the person that you're discussing. I then want to think about what the most clinical, what the most recent clinical plan is. I want to know the results of the most recent tests, and I want to be able to give the family the most up-to-date and most real-time information. What's important to think about as clinicians before we go into this conversation is, what do we want to achieve from it? What do I want as an outcome from it? By the time I leave the room, having had the conversation with the family members, what knowledge do I want to be shared? What information do I want to gain? And how do I want to leave them feeling? If I don't know what that is before I go into the room, I'm at very high risk of getting lost throughout the navigation of the conversation and ending up in a very, very different place to where I perhaps wanted to end up. The other thing that's really important is about considering our clinical options before we go into the room. I think it's essential that we know whether or not certain options, treatment options, are available before we try and offer them to the family. It's about managing expectations and ensuring that we give them realistic information in a compassionate way. The other thing that's really important is thinking about, once we're in the conversation, how do I communicate with my colleagues? So that might be my nurse, might be the doctor with whom I'm working, or the specialist nurses. Are there cues? Are we going to maintain eye contact? How do I signal to you that perhaps it's your turn to take control of the conversation? Another thing that might be worth thinking about is, how do we signal to each other that we need to take a break? These family conversations can often become quite emotional and quite heated, considering the content and the context of what we're talking about. And I think it's really, really important before you go into the room, planning the conversation, to ensure with your colleague, if things get heated, if perhaps we need to take space, we need to take time, that I can communicate that in a way that looks after the family, but acknowledges for everyone, maybe now isn't the best time to chat. Let's take a break and revisit things in a little while. So moving on to the second top tip, which seems timely actually, is to take a breath. Literally take a breath. I spend a lot of my time at work involved in cardiac arrest calls. I spend a lot of my time running around to cardiac arrest calls. And as such, often when you're involved in these scenarios, you've been running around, you're physically exhausted, in addition to the fact that you're already on shift. If you've come running from a cardiac arrest call, or you've been doing something, you've been caring for the patient, and it's physically, you're out of breath, just take a second to pause. Make sure you smarten yourself up before you go into the family. And this, it might sound odd, but have a quick look over your uniform, check for fluids, check for any blood stains. Make sure you haven't got little bits of apron in the back of your collar, because it's these small things that relatives and families notice that might make a really, really big difference. I think it's really important that you turn your phone off. Okay, and in terms of bleeps, I think if you can, it's really key that we take the batteries out, because there's normally no way to turn bleeps off. If you can't take the batteries out, if you have to have your bleep on you, I would wonder, maybe are you the best person or the most appropriate person to be having the conversation? I think there's nothing more interrupting or nothing more off-putting than in a family conversation than having a noise of a bleep or the noise of a text coming through. So it's just something worth bearing in mind before you go into the room. And as I said before, it might be a Thursday afternoon for you, but what's really, really key to remember, as I'm sure all of us do in our daily practice, is that our day, our normal job, may very well be the worst day of this family's life. And what might be a normal, regular part of our day might be the start of a nightmare for some of our families. Moving on to tip 3, my top tip would be to be honest in a meaningful way. So I tend to think that this relates to health literacy. Healthcare, and especially intensive care and care of people who are really critically unwell, is often full of jargon, technical language, and phrases that sometimes can go right over the heads of not only our relatives, but sometimes clinicians and other members of our team. It's about making information and diagnoses accessible and in a way that means something to our families. Often I found in my experience, when I'm having these conversations, families may not hear certain things, and especially if we're discussing complicated, complex medical topics, it might not all go in. That's not to say it doesn't for some of our families, but it's worth thinking about and just taking an extra second to make sure that what you're saying is definitely being heard. If you don't know something, say you don't know something. There's no point leading people around trying to find an answer because you're panicking. In my experience, I found relatives and families will appreciate the honesty. It's worth saying at this point that you might want to know who you're going to go to find out the answer. But if you don't know, just say you don't know. This one I'm very passionate about. I tend to say we need to use the word dead. we need to use words dying, and we need to use the word death, because there's a certain sense of finality and a certain sense of significance to those words, attached to those words. Phrases like passed away, moved on, gone to another place, I think for me, they're euphemisms, and they can often lead us into really tricky situations, actually. I've had relatives before say, oh, I've been told that they've moved on, I've been told they've moved to another place. Do you know which ward that might be? Or do you know how I can find where it is that they've been moved on to? So we're almost setting ourselves up for failure there. It's really important, I feel, that when we're saying their relative has died, that they hear that. My fourth tip would be to learn to be comfortable with silence, which is a very bizarre concept. We all, in every line of work, especially in healthcare, we feel awkward with silence. And I think there's there's many reasons for that. I think we feel nervous. I think we panic. And I think that sometimes we just witter on and we ramble on. And actually silence, I've found, throughout my practice and then conversations I have with relatives and some of our patients, is a really, really valuable thing. Try not to fill every void. Try not to fill every gap with sound. Silence slows the pace of conversation. And when you're going 100 million miles an hour and you might be explaining really significant things, silence just stops the room and pauses everyone and allows our families and allows the relatives that we're speaking to just take a second to absorb what it is that you're telling them. They might hear certain things. They might hear also, they might not take on board everything that you're saying, and silence just gives them time and it gives them space. It also allows them to ask questions, and it allows them to process what you've said to them, and it allows them to try and transform their queries in their mind into sound. It's okay to say we're sorry within the same breath. It is okay to say that this is an awful, awful situation. I tend to say I'm really sorry that I'm meeting you under these circumstances. And silence, for me as a clinician, also allows me to ensure that I'm using what we call active listening, which is something that when I first heard about it is actually a really difficult concept. So the concept behind active listening is that you are paying full attention to the person who's talking to you and not spending that time trying to work out what you're going to say next. And it's actually really, really, really hard. Try it next time you're having a conversation, I don't know, with your housemates or your family. The amount of time anyone invests and spends in thinking about their next line is actually incredible. So in terms of silence, it slows the room down, it slows your pace down, and it just gives you a second to stop and to allow relatives to absorb what they're hearing. And I think also silence allows us to just grasp how tragically sad some of the stuff is that we're saying. Yeah. So it's not that we're running out of things to say. It's not that I feel awkward and I'm not sure what I should say next. But the information, what I'm saying, and the points that I'm making are awful. And some of the things that I'm saying, some of the news I'm giving is horrific. And it's right that we stop and acknowledge that. There's nothing wrong with that. My fifth tip, my final tip, will be to look after yourself. So to acknowledge that these conversations are tough. They're tough on us as clinicians. They are tough on relatives, but they're really, really hard. It's often, I think, with many things, there's many times in nursing I've thought this. We sometimes know when we've got it right, but we definitely know when we've got it wrong. And I think it's the same with conversations, difficult conversations. Acknowledge they're tricky. Acknowledge they can make us sad, and acknowledge that they might be really difficult to emerge from and step back into your day-to-day job. Take a moment for yourself before coming back out. If you're a bedside nurse and you've got clinical, you're looking after a really busy patient, come out of the room, grab a glass of water, just take a deep breath and acknowledge that what you've been in, the situation you've been in, might be desperately sad. And the information that you've communicated might be really, really awful. But just take a moment, recenter yourself, take a big deep breath, and rejoin, whatever it is that you were doing beforehand. As part of the cardiac arrest team, I think this is particularly important for what we call our core members of the cardiac arrest team. So obviously everyone on the cardiac arrest team is essential, but there's certain members of the team who carry the crash bleep in addition to their clinical responsibilities. So medical registrars, the critical care outreach nurses, and many other members. So they've got a full-time job in addition to responding to 222 emergency calls. So they're dropping what they're doing and running along to this that they were doing before, and so it's been very protracted. It's difficult not to carry that with you. It's difficult to go back to what it was that you were doing before, or go back to standing in the lunch queue. So there's nothing wrong with acknowledging that not only are these conversations tricky on our relatives, they're really, really tricky to be part of as clinicians, and that's okay. Kind of moves me into my next point, in that it's really worth checking in with the clinicians with whom you've had the conversation. So going back to how we planned the conversation at the start, just take a couple of minutes after the chat away from the relatives to say, how do you think that went? And are you okay? How do you feel? These things are really sad, as we've said. I tend to like swapping contact details, especially if you're working with a number of specialists. If you've decided perhaps, we need to take a break, let's meet up later. It's worth swapping contact details just to make sure that you haven't got to track people down, in the huge abyss that is, or that can be the NHS and the hospital. Make sure that you stay in contact. And that's also really, really useful for debriefing situations. Debriefs is quite a key part of my job as a resuscitation officer. And it's really, really important to make sure that we can capture everyone that was part of, traumatic scenarios or emotionally tricky clinical situations, just to ensure that we're looking after each other, we're learning from each other, but that we leave these conversations getting across to the family what it is we wanted to get across, making sure they feel supported, making sure they feel looked after, making sure they feel loved, because that's a really, really key part of this, and also making sure that we support each other as clinicians, and everyone else within the wider team. So that kind of wraps up my 5 top tips for difficult conversations. I think we were asked the question earlier. Someone said, what would you say is the best way to approach bad news over the telephone? Which is a really, really good point, actually, because I haven't talked about that at all. So the first thing I think I would say, if I were talking about bad news over the telephone, I would make sure, first and foremost, actually, you're speaking to the right person. Make sure you're speaking to the right person, by which I mean the next of kin, okay, the most appropriate next of kin. I would say sorry. It is okay to say sorry. I think that's a really, really important point to make. I would want to be able to provide a rationale, so I would want to be able to provide a very good reason. So taking the example of the operation being cancelled, I would want to be able to provide what I would expect as a relative. If I were a patient and somebody called me telling me that my operation had been cancelled, I'd want a really good reason why. And I think that that's what our patients deserve. I think it's about managing expectations, being transparent, being honest and open. And what I like to do as well, what I think I would like to do is I'd call and I'd explain what happened, and then I might say, can I ring you back this afternoon just to let you know if things have changed? It gives them a time scale, it gives them a time frame, and then make sure that they're not just left in the lurch. What do I do now? Where do I go now? Will anyone contact me? So I want them to feel like I haven't just you've forgotten about them. I want to make sure that that continuity of care, if you like, is maintained. And then, of course, I would document everything and make sure that that we had the correct contact details for the next time that we were going to get in touch with them. We've had some other questions. So someone has said, how long can you keep the silent? How reasonable is it to stay silent for? And this is a really tricky one, I suppose. I think this is something, I guess you can kind of play with it, for want of a better phrase, as a clinician. You want to leave things quiet long enough to acknowledge what's going on. I would say if you're being quiet, if you're allowing for silence to make a point, that's kind of a judgment you have to take. Sometimes I leave silence. So I tend to, when I'm asking people if they have questions, because I do this quite a lot in teaching, I'm asking people if they have questions, I tend to leave silence about 10 to 12 seconds or so. And it's that, whatever works best for you. For me, that's kind of where I get to the border of someone has to speak now, otherwise we're not even moving anywhere. But it allows enough room for people who are worried and nervous about asking questions to ask them. It allows time and space for people who, if they don't have questions, they might use that time to form them. And I think it also allows time for me, just in my mind, to make sure, have I covered everything I want to cover? Yes, I'm happy to move on. So I think you have to, case by case basis, but have a play around with it, use it, see how you feel with it. It's a learning process. And I'm not by any means, 100% comfortable with silence. I think it's a really useful tool in these kind of conversations. But have a play with it, see what works for you, and see how it impacts on the conversations that you have, I suppose. Someone else has also asked about locking the door in a private consultation. What happens if people, become aggressive, and how to maintain your personal safety? And that's a really, really good point, actually. As a resuscitation officer, we're always thinking safety first. And I think, we're taught in our, escalation training, and we're taught in how to deal with confrontation, to always position yourself by the door. So things like that. And I think that is really important. That comes back to my very first point about planning the layout of the room. I tend to always let somebody know where I'm going, okay, by which is normally the nurse in charge of the clinical area, or the bedside nurse, just so they know where I am. Not to come looking for me if I don't come back, but just an awareness that it's not just me in that room on my own. It's worth knowing if there are kind of panic buttons, if there are alarms and buzzers in that room, where are they? Do they work, and how to use them? But it's a really valid point. I think perhaps an alternative to locking the door might be popping a sign on that says, engaged or in use. So I would say have a look around, the relatives' rooms of your local areas, see what your clinic areas offer, and find the best spaces from there. But I can't overemphasize how important it is that we plan that space, that it's quiet, away from the hustle and bustle, and that we give the family, and we give ultimately the patient, the respect and dignity that that such a topic warrants, I suppose. So I think that's what my answer would be to that one. So with that, we've come to the end of the video. Thank you for coming to the webinar. Thank you for attending the webinar. It's been brought to you by the Florence Nightingale Mentoring Programme here at King's College London. You can also watch a recording of this webinar, which will be prepared and posted online shortly. It'll be on the King's YouTube nursing channel. Definitely stay in touch. Keep your eyes on the website and the King's alumni and King's Nursing Twitter for future webinars. And I hope you've enjoyed the session.